After a wonderful conduction of the first session, now we move on to our second session. This session would be dealing with SGLT2 versus GLP1 receptor agonist and their pragmatic placement in the present era. To chair this session, I would like to invite Dr. Ajay Garg, who is Associate Professor in Department of Medicine, Government Institute of Medical Sciences, Greater Noida, Dr. Mahendra Meena, who is Assistant Professor in the Department of Medicine, Government Institute of Medical Sciences, Greater Noida, and Dr. Tarun Goel, who is Senior Consultant and Intensivist at Lee Crest Hospital and Prem Dharam Hospital, Vasundhara, Ghaziabad. To moderate this session, I invite Dr. Arun Singh, who is Senior Consultant Endocrinologist at Sarvodaya Healthcare, Faridabad, and has numerous research papers in national and international journals. So I think the chairpersons and moderators have joined. And over to you, Dr. Arun, for the further proceedings of this session. Thank you.
Very good afternoon, everyone. Thank you, ma'am, for introduction and for the honor. So after the very interesting session on the connecting the dots of hypoglycemia and ASCVD risk, we second controversial or debatable topic whether to choose GLP1 RAs or SGLT2 inhibitors as second-line anti-diabetic agents. So that is the title of session, the pragmatic placement of SGLT2 inhibitors and GLP1 RAs. And to do the justice, we have very senior physicians, diabetologists from the North India. So Dr. A.K. Shukla, Dr. Brij Mohan, Dr. Lalwani, and Dr. Sanjay Arora. So these all esteemed faculty do not need any introduction in the field of diabetes. So they have more than 2 to 3 decades of experience in diabetes, and many contributed to many research. They have been investigators of many clinical trials in the field of diabetes, and they all are actively involved in educating the general practitioners and physicians to improve the diabetes care. So before I invite the panelists to comment on the subtopics or the different parts of the session, so why we are having this debate actually. So we all know our understanding and the approach to type 2 diabetes has evolved in last decade very rapidly. And still there has been quest for ideal anti-diabetic agents. And fortunately, both these groups of anti-diabetic agents as a class, SGLT2 inhibitors and GLP1 RAs, they do possess many properties of ideal anti-diabetic agent. One of many important aspects already been discussed in the previous session, there should not be hypoglycemia. We have to get HbA1c within target to prevent our patients of diabetes from different complications in future, but then simultaneously we need to protect our patients from the risk of hypoglycemia with tight control. And then cardiorenal protection, that has been other area of interest in treating especially type 2 diabetes population. Then many non-glycemic benefits or pleiotropic effects, like most of type 2 diabetes patients would be obese and will have multiple other comorbidities. So impact of these anti-diabetic agents on different comorbidities, those have become the important considerations while choosing the class of anti-diabetic agent. So starting with the lifestyle modification, metformin remains the first line of therapy, but then after that, as per the international and local guidelines, there are multiple determinants which decide the choice of second-line anti-diabetic agent, like HbA1c, the comorbidities, the presence of ASCVD, CKD, heart failure, the glycemic status, the risk of hypoglycemia, tolerability. So we are all going to discuss all these determinants of choosing the second-line anti-diabetic agent, and as a class, both GLP1 and SGLT2 inhibitors are a wonderful class. So we'll be having inputs from our panelists. I'll start with Dr. A.K. Shukla, And I'll put the questions regarding the efficacy. So I'll start with the efficacy, as these are, of course, anti-diabetic agents, and we are using them with the primary objective of bringing the glucose levels in range. So in terms of efficacy, how do you find the two classes of anti-diabetic agents? How will you prioritize your choice based on different HbA1c levels at presentation? Or is there any difference in the efficacy of these two different classes of antidiabetic agents in different subpopulation or subgroup of patients? Dr. Shukla, please.
Thank you, Dr. Arun Singh. In fact, you have already initially you have given the introduction of these two drugs. Now, various studies has been done for GLP1 RA, and we are going to deal with that. In fact, we have got 7 types of this GLP1 RA. First came the linxanatide, where the Alexa was the trial which was done, and they could found that SGLT2 in average was 0.8 to 1.1%. That was reduction seen. Then came the liraglutide leader trial. They could find the average HbA1c was 1.6% reduction. Then came semaglutide subcutaneous. It was sustained 6, which showed that 1.3% was the HbA1c reduction. Then came exenatide. Excel was the COT which was done, and they could find the reduction of HbA1c from 1.1 to 1.3%. Albuterol harmony trial was done, where they could see only HbA1c reduction of only 0.58%. Liraglutide in the rewind trial, they could find that 1.2 to 1.52% was the reduction of HbA1c, which was the maximum till now. And the semaglutide oral. Now, 1 year 6 is continuing, and we have not got the results till now. Till now, we have seen that 7 COTs which has been done using GLP1 RA. The meta-analysis conducted on the efficacy of GLP1 RA suggested that total HbA1c average reduction was 0.8% to 1.13%. Fasting blood sugar reduced from 21 to 33%. Postprandial glucose reduction was 16 to 41%, and the average weight loss was 0.7 to 3.95%. And good robust blood sugar control with HbA1 reduction was seen with the GLP1 RA. Now, various SGLT2 inhibitors which we have got right now, we have got dapagliflozin, where the SP reduction was only 0.5 to 0.52%. Canagliflozin HbA1 reduction was 0.73%. Empagliflozin 0.62%. Remagliflozin 0.66%, and ipragliflozin 0.7%, and tofagliflozin was 0.7%. So these are HbA reductions which I have seen with the SGLT2 inhibitor. In their meta-analysis, what they could conclude was average HbA reduction with SGLT2 is 0.5 to 0.8%. Blood sugar fasting reduced from 20 to 35 milligram per day, and postprandial they could find 17 to 40%. And the weight loss was from 1.6 to 2.5 per kg. So it is a clear-cut evidence that this GLP1 RA had shown better HbA1 reduction in compared to SGLT2 inhibitor. But the only problem which arose was because it's a cost factor, and then it's injectable. So one daily dose for the both of them is same, but the cost factor is one of the factors which has remained illusion for the many of the patients, and then injections. So GLP1, it is clear evident that GLP1 analog is superior in HbA1 control. The both SGLT2 inhibitor and GLP1 RA were found to reduce MACE to similar degree in patients with the established cardiovascular disease. Both had the same risk of myocardial infarction and cardiovascular deaths. So both of them are similar in their findings. Whereas GLP-RA significantly reduced the relative risk of stroke, which was not seen in the SGLT2 inhibitors, and they could find that the incidence of heart failure and the progression of DKD was better controlled with the SGLT2 inhibitor. So if you say, therefore, the GLP1 RA should be preferred for the patient of atherosclerotic vascular disease at high risk of CVD, while SGLT2 should be preferred for the patient of heart failure and CKD.
Sorry to interrupt, Dr. Shukla. So let's restrict here to HbA1c efficacy, and what I have clearly understood, though you have put the data from trials which do not compare the GLP-1 RAs and SGLT2 inhibitors directly, so that is indirect comparison. But overall, yes. So in terms of efficacy, the magnitude of HbA1c reduction, I think GLP-1 RAs are the clear-cut choice, or they are superior to the SGLT2 inhibitors, of course, with the constraints of affordability and acceptability to the patient in terms of being injectable. So, but then for the ASCVD or the cardio protection, I'll be inviting next panelist, Dr. Brij Mohan, to throw light on the differences in the effect of these two different classes of antidiabetic agents on the cardiovascular outcomes. I have few questions for the in terms of HbA1c for Dr. Shukla. I'll be coming back to you later.
Am I audible?
Yes, sir. Yes, sir. Please. So the question to you is, so of course, apart from the efficacy of antidiabetic agent or the difference between presenting HbA1c and target HbA1c, the next very important determinant of choosing between two is the shared benefits by both group of molecules, the cardio-renal protection. So I'll be focusing on cardio protection with you. So is there a difference in the outcomes with these two group of molecules in terms of primary prevention of ASCVD, in terms of secondary prevention of ASCVD, and also heart failure? So that cannot be left alone. And as Dr. Shukla was already pointing out, the components of MACE. So is there a difference in the outcomes in different components of MACE with different molecules?
Thank you, Dr. Arun. Thank you, Dr. Gupta, for giving this opportunity to me for being a part of DID, Dialogue in Diabetes. I don't have anything written with me, but I do understand that this is not meant for reading from the screen or reading from the paper. This is just by conversation that we need to learn. Dialogue in Diabetes is meant for that. Now, your first query is regarding effect of two groups of drugs, GLP-1 RA and SGLT2 inhibitor, and their effect on ASCVD. The first part is regarding that. I do agree with Dr. Shukla that here GLP-1 receptor agonists are the clear winner. They do prevent ASCVD because of various reasons. Whether it is weight loss, which is more with GLP-1 receptor agonist as compared to SGLT2 inhibitor, and there are a number of evidences for that. We do have injectable GLP-1 receptor agonist for obese non-diabetic patients also, and that is approved in US. Other than that, by reducing weight, they do reduce insulin resistance. By reducing weight, they also improve lipid profile, which probably is the negative effect of SGLT2 inhibitor, where we see that there is a LDL with GLP-1 receptor agonist. And that I don't argue on that what is the significance of rise of LDL in using SGLT2, but various trials have shown that SGLT2 inhibitors do increase the LDL level to some extent, although they do reduce the CV events. We'll come back to that. Now, regarding ASCVD, clearly the atherosclerotic process starts very early in the disease, in the life cycle of the person, in diabetics also and in non-diabetics also. But whatever trials we have currently are meant for, with GLP-1 receptor agonists, are meant for secondary prevention. And here the clear-cut mandate is that GLP-1 receptor RAs are better as compared to SGLT2 inhibitor. The better effect of SGLT2 inhibitor, as already pointed out by Dr. A.K. Shukla and by you, Dr. Arun, is on DKD, whether it is primary prevention or secondary prevention. Both are taken care by SGLT2 inhibitor in a better way as compared to SGLT2 inhibitor. And heart failure, whether it is primary heart failure because of ASCVD or heart failure, which is a diabetic cardiomyopathy per se, that is also prevented by SGLT2 inhibitor better as compared to GLP-1 receptor agonist. I'm not going into detail of various trials, but that is what I understand as of now, that if you want to prevent heart failure and want to protect kidneys, use SGLT2 inhibitor even for primary prevention. And we do have data for primary prevention with SGLT2 inhibitor. But ASCVD, definitely SGLT2 inhibitors are on the second place as compared to GLP-1 receptor agonist. Dr. Arora.
Thank you, sir. Thank you for clarifying the thing. So you go with the consensus, evidence, and international guidelines, and that is the way to subcategorize, I think, as per the latest guidelines for last 2-3 years at least. So subcategorize patients depending on the predominant comorbidity. So if it is kidney disease or the heart failure, probably SGLT2 inhibitors or the better choice. And in terms of ASCVD, the GLP-1 RAs are there. If acceptable and affordable to the patient, of course. So let me move to the next question with Dr. Kumar Lalwani, sir. So we have discussed the efficacy, we have discussed about the cardiovascular outcomes, the impact on the primary and secondary prevention of ASCVD and heart failure. Moving ahead to next very important determinant of decision making, their uses in patients with kidney disease, established kidney disease, in fact. So will the presence of CKD have an impact on the efficacy of these two group of molecules? Also, that is equally important. And of course, the impact of these two group of molecules on the progression of CKD and their efficacy and safety in patients with kidney disease.
Thank you for the question. The most important thing, first of all, I would like to thank the organizers for inviting me for this session. And secondly, I must thank Dr. Brij also for clarifying that we are not going to read from the notes, although note sheets are ready with everyone. But then where is the scope of adding our own inputs? So yes. Thank you, Dr. Brij for that. So the most important thing with which I would like to start with, these are the drugs, the two classes of drugs are such that they have excited and thrilled us, no doubt about it. But 1,75,000 patient data backing them with 700 publications, which have made 90 to 100 alterations and tweakings and defining of the guidelines, and the latest guideline answers your first question, moderator, sir, when you asked that there is a debate. There is no debate now. ADA also agreed either of them. So the 2021 guidelines say you can start either of them. So the debate it has been narrowed down so beautifully with the robust data, and these data were never available to us even before, even with RAS inhibitors or even with the statins, for example. The pleiotropy they are showing is wonderful. The other important thing which I would like to highlight for my audience is that let us try to relearn and unlearn previous things, and dogmas should be challenged and should be shattered, because these are the drugs which are doing it. And see, the diabetes has always been considered MACE and hyperglycemia and MACE, and they have just removed this myth and shattered the myth. Absolutely. And many of us, like you, who are senior enough, who have practiced, we believe that diabetes is never has been hyperglycemia. For 30 years of last experience, I have seen diabetes is not just hyperglycemia. What are we doing? Probably diabetes is a syndrome which probably is now being tackled through their pleiotropy, which is yet to be defined, and hyperglycemia just there is by the way on the side. So maybe things will be absolutely redefined. So coming to the questions, where to place the drugs and how in the kidney failure. So let me bring out three very important facts from Credence and from DAPA-CKD. And of course, some data is out from SCORED. SCORED is now has been stalled and stopped almost because funds are not there. So sotagliflozin data are also with us now. So I must tell you, Credence clearly showed that all diabetics who are having any amount of albuminuria beyond 300 and EGFR above 30 to 90 will be benefited, and the benefit is around 40%, and not simply albuminuria. The hard endpoints are escalation of the end stage kidney disease, 50% more, 57% in Credence, sustained 57% reduction in EGFR, sustained doubling of the albumin creatinine ratio, cardiovascular renal death, and all this was studied in Credence as initial questions being asked, pre-specified endpoints, and successfully Credence with full marks came out, and it was stopped prematurely. So such was wonderful the result. And then DAPA-CKD repeated this with non-diabetic patients also. So metformin doing something good question was also solved because non-diabetics were not taking any metformin. Still, the diabetic improvement or non-diabetic improvement in kidney disease was wonderfully equated in DAPA-CKD, and the same has been coming out from sotagliflozin SCORED data, whatever is available with us. So progression of renal disease, cutting down EGFR from 4 ml per year fall to 0.92 ml per year fall has never been seen with RAS inhibition. 20 years back, we have some limited data with captopril and irbesartan and losartan, and absolutely 22% was the thing which was achieved with them. We are having something unique this time, and that is the reason of thrill. The kidney progression, disease progression, progression of albuminuria, regression of albuminuria favorably, everything going favorably in favor of gliflozins. Now coming to GLP1. GLP1 again, leader was the first indicator which told us that nephropathy is improving. Then same thing happened with sustain, and the same thing is happened with the rewind also. So Dula, that is the dulaglutide, semaglutide, and liraglutide stand tall. So all these are human GLP-1. So there is a heterogeneity here, which is not there in SGLT2, except Vertis, which is ertugliflozin. To me, I think I will never be using that compound. Let us not discuss it even. So all other gliflozins are wonderful. But when it comes to GLP-1, these are human GLP-1 analogs, which are not xenopeptides. There is no X in their names. So these are the non-HeLa monster peptides. They are all wonderfully doing well in renal front also. Another thing which we must not forget is the stroke. Stroke benefit is also one of the pleiotropic benefits, which is wonderfully has been re-emphasized in 2020 last year's ESD, wherein we found that same SEMA, Dula, and Lira coming out tall with their figures for stroke prevention. So this is again unlearning. You will remember stroke. We always remembered something related to blood pressure and stroke. This vascular bed is above head is blood pressure dependent. That myth is also broken. So many myths and many dogmas are being shattered with these compounds. I think the SCORED also told us something on. The soloist also told us something on the heart failure with preserved ejection fraction. The Deepak Bhatt presented a paper I read a few days back, wherein preserved ejection fraction was also improving as per Deepak Bhatt's analysis in soloist data. So lots of things as far as the pleiotropic benefits are concerned. And adding life to kidney, adding life years to the person, adding quality life years to the person and the kidney both.
Thank you, sir. Thank you for in-depth insights into different trials of different molecules of both classes. And you are absolutely right. Every physician, every clinician treating patients with diabetes is so much excited with the availability of two different classes of drugs, which is helping us to manage diabetes beyond the numbers, not just the HbA1c.
Absolutely.
Adding years and reducing the risk of complications, protecting the kidneys, protecting the brain, protecting the heart. But unfortunately, despite of availability of all these molecules, there is no shortage of patients out of range HbA1c, getting different complications, developing kidney failure. So when we have two molecules with so many benefits, so that is the next question to esteemed panelist, Dr. Sanjay Arora. So there would be still patients who will be developing these complications, the MACE events, the heart failure and CKD, and we have two molecules which only does not address the number HbA1c, but they also have multiple non-glycemic benefits. So do we gain something extra when combine these two in terms of HbA1c reduction, in terms of cardio-renal protection, when we should think of adding the two? So our debate is whether to choose one of two, but when we have both available, so why not to choose both of available and pass on the benefits to our patients to protect their organs from end organ damage? So what is your comment on that, when we should be thinking to combine these two agents, and what would be the impact on HbA1c as well as the cardio-renal outcomes, and is there a safety concern of adding the two? Dr. Arora, please.
Thank you, Dr. Arun. Yes, the topic is very, very clear now that since Dr. Shukla, Dr. Brij, Mohan, Dr. Lalwani has already elaborated a lot about it. So as you said, that the lacuna will always be there. We've got a lot of molecules available with us, but still we are unable to get a 100% outcome. We are working on it, and probably, I don't know, because it's a multifactorial disease, and we are focusing on some aspects and trying to get a good outcome. But getting 100% is still awaited, and we are still working on it. The combination of the two molecules is a very interesting topic. Combining the two molecules is, it was discussed sometime, and probably practically my personal experience is not there. I have not combined the two still. But as elaborated by Dr. Brij and Dr. Lalwani, the benefits are quite significant. The benefits are quite significant. If we recall back that with the rosiglitazone controversy, the issue was trying to see the benefit, trying to see cardiovascular safety of the molecule. But now we've started getting benefit out of it. We're not just looking at the safety of the molecule. These two molecules have given us very good benefit. So when to combine the two molecules is very clear that if a patient has cardiovascular atherosclerotic problems, we have to think of these molecules. It is very well clarified without any controversy that if a person is having some evidence of cardiovascular disease, we have to think of these molecules early in the case of treatment. Initially, it was lifestyle modification, metformin, and now ADS segregated according to the risk factors. A1C is not the only criteria now. So if a person is having good evidence of cardiovascular disease, we should start thinking of GLP1 receptor analog, or maybe with this molecule of SGLT2 inhibitors. Combining the two will definitely give an add-on benefit. It has the additive effect. And the results are good. Whatever literature I could scan through, they all show good benefit in the combination of the two molecules. May it be the MACE outcome, may it be the atherosclerotic benefit, which is more with the GLP1 receptor analog compared to SGLT2 inhibitors. May it be the hemodynamic benefits, that is also additive effect. The glycemic control, the reduction of A1C is also additive. We can get a good result and a good further reduction in A1C values if we add the two molecules. The insulin sensitivity, the beta cell function, that also improves. The blood pressure reduction is always there. The weight management is always there. We are getting good reduction in weight with both the molecules. And probably this weight management is giving us a good cardiovascular outcome, because more than 85% of diabetic patients are obese. So if we are hitting at the basic pathophysiology of the disease, that is giving us a very good result. The lipid profile, as Dr. Brij Mohan elaborated, Dr. Lalwani has also elaborated that there's slight increase in LDL. Still, we are getting good outcome in the cardiovascular outcome. So weight management, the visceral fat redistribution is also good. The benefit on the non-alcoholic fatty liver disease. All these are additive effect. Whatever results I've scanned through the literature, they are all additive effect, and they combine the two results to get a good, as had been elaborated by Dr. Shukla. The reduction of A1C is also additive. So all these molecules are giving a very good response. The natriuretic effect on the diuresis, the benefits on the kidney outcome. If we see the segregation, which has already been discussed by the two early doctors, that benefit on kidney is much more with SGLT2 inhibitors. Benefit on heart is much more with GLP1 receptor analogs. But the combined benefit of both is good. Reduction of heart failure is more with the SGLT2 inhibitors. So if a person has evidence of these problems initially in the disease, we have to think of combining the two. But as you said, that we are not getting a good outcome with just one molecule. So why not add on with the two molecules and get a good result outcome in the ultimate patients?
Thank you, sir. Thank you, sir. So we expect some complementary and some supplementary effects, I think, both group of molecules. And to support these effects, we have data for some of the outcomes, at least for the additive effects on HbA1c reduction, additive effects on weight loss. We do expect benefits in terms of cardiorenal outcomes, though we do not have a data from direct randomized trial or something like that. But I don't think...
I like to add, there are two
Yeah.
trials going on right now. The duration study, which clearly is combining GLP1 receptor agonist with SGLT2 inhibitor. And we are sure, I have used it personally. I have used it weekly GLP1 receptor agonist as injectable and SGLT2 inhibitor as oral drug. And the results are excellent. And we are likely to get good effects in future. We will have data of these studies, two studies going on right now with combining GLP1 receptor agonist with SGLT2 inhibitor in the same patient in diabetes.
I agree, sir. So personally also, I've been using them whenever possible together. And the biggest advantage I see, apart from the additive benefits in different outcomes, in aspects of different outcomes, you protect your patients from the hypoglycemia. We had just the previous session. So biggest obstacle in achieving the intensive glucose control, and then the risk of the outcomes of increased incidence of hypoglycemia itself. Probably you cannot achieve similar levels of targets with the secretagogues that safely. So negotiating safely to the stringent control has become very much possible with these newer classes of agents. And before I take questions from the attendees, I have a few questions from my side itself. So as our panelists were talking about, diabetes is not just about the numbers or the hyperglycemia, basically the glucose or HbA1c. But I started with the impact on HbA1c of these two class of antidiabetic agents in which you will choose. So the question to Dr. Shukla, who has a discussion on the efficacy. So in the era of these cardiorenal protection outcome trials, does the HbA1c still matter? Or we can just offer the cardiorenal protective medicines and forget about HbA1c, let it be at 8 and 9?
You see,
does that make a sense?
Has been, since last 3 decades, we have got all these COTs which has been there. They have taken this as a biomarker. And we have established that HbA1c is the one which can predict and which has shown a good effect that cardiovascular disease is there and how much is there. And we have classified in various ways. But now if you see there are a lot of disadvantage of this HbA1c alone. So we have come to the TIA, that's time in range. That's one thing. After SMBG, this CGM which has given us the insight about when the hypoglycemia is happening, when the hyperglycemia is happening, how is the control. So this is going to give us a good insight more than this HbA1c.
Yeah, sir, my question is slightly different. So that is the time in range is like a complementary diagnostics to find out whether the patient is in targets or not. So so broadly again re-putting the question. So does the glycemic control or target still matters, or you need to just offer the cardiorenal protective medicines and forget about the glucose levels? Can we leave the numbers aside?
No, not at all. We have to control it, in fact, and in fact, the control is very, very important because the hyperglycemia, they precipitate cardiovascular events. And if you see the hyperglycemia at certain stage, independent factor for the acute coronary syndrome. So we cannot forget that, and we have to consider and take into detail.
I agree. Yeah, Dr. Lalwani, sir. Yeah, please go ahead. You are mute, sir. Please unmute yourself. Dr. Lalwani, sir, you are mute.
Yeah, sorry. Let me add, when it comes to choosing these two drugs in therapy, the guidelines 19 onwards have clearly said HbA1c is not to be considered at all when there are compelling indications. When there are compelling indications with atherosclerotic cardiovascular disease pre-existing, CKD, heart failure pre-existing, no need to think of HbA1c. You have to give either of these two, GLP1 receptor analog or SGLT2 inhibitor in the later case when heart failure and CKD are there. When atherosclerotic cardiovascular diseases, latest guideline says either of these two can be added. Now, this is irrespective of HbA1c because HbA1c in any subgroup analysis, in any trial, in any data has not shown, even glycemic effect themselves have not shown to be related with the benefits which these drugs are providing. That's what we are talking all through the time. These drugs are working beyond glycemia. Forget glycemia when you are choosing one of these drugs and you want to benefit your patient, you have to push them in. If the HbA1c is absolutely in the target, say for example, your patient is 6.5, 6.8 already and you don't have any scope to add these drugs and you are not running with these drugs, try to withdraw any of the previous drugs. This is the recommendation now coming from the opinion leaders across the globe. Try to withdraw something. Or John Hughes once said, wait for an immediate opportunity when you can add.
Yeah.
So you have to have these in the therapeutics. That's very important, not to forget.
True. So, but then I think that statement or recommendation is more so in the context of when the HbA1c is in target actually.
Yes.
So they are not telling you to forget about HbA1c. They are telling even if the HbA1c is range, then still you can add these two agents to reduce the ASCVD and the renal events. But they are not telling us to forget about the HbA1c.
No. They are telling when it comes to choosing the drug, the drug, don't bother about HbA1c.
Yeah. Sir, so I would differ here. So trying to clarify, it is not to bother when HbA1c is in range. But we have bother when HbA1c is 8 or 9%. Any comments from any of previous?
Yes, I like to support what Dr. A.K. Shukla said and go against what Dr. Lalwani said. The guidelines say that target HbA1c, that there is no doubt about it. But only thing is, as you, Dr. Arun clearly said, once the A1c is within the target, then only you reduce some of the drug and add either SGLT2 inhibitor.
That's what I am saying, sir.
But you said don't worry.
No,
there is a need to worry.
When HbA1c is below target, withdraw some drug and push them in if it is compelling indication.
Now you have.
Let me put one more question. Let me put one more question. So if the HbA1c is 8% of patient or maybe 8.5%, more than 1.5 or 2% above the target HbA1c of a patient, and he has ASCVD, or let me not subgroup clearly the patient, he needs cardiorenal protection. So would you choose GLP-1 RA or SGLT2 inhibitors? Would you give a consideration to the difference between target HbA1c and baseline HbA1c, even if there is a candidate for cardiorenal protection? How will you choose?
Now, here I like to add that recently concluded ADA last month clearly showed that twin cretins, that means they are acting on both GLP-1 and GIP. They are reducing HbA1c up to the range of 2.5. And that is going to crack the whole thing. Once you say that start with dual therapy, once the A1C is more than 1.5 above the range, that is what is the current guidelines, that if the baseline HbA1c is more than 1.5 above the target, you start with double drug therapy, a combination of drug, maybe in separate or with fixed dose combination. Now, if you have drugs which are giving organ protection, which are proving best of the both worlds, and they are reducing HbA1c by 2.5, as the data presented with twincretin has shown, that is going to change the thing.
May I add here, sir? May I add here? Most important thing with the dual and agonist, that is GIP, GLP-1 tirzepatide is still phase 2 completed, phase 3 is yet to complete, and data are yet to come. But when it comes to GLP-1 receptor agonist, you will get 1.5 of HbA1c reduction with GLP-1 alone easily. And in many trials, this has been proven that adding GLP-1 does the trick. But if it is not completing the job, then of course you are open for the next drug, which may be SGLT2 inhibitor. But when it comes to atherosclerotic cardiovascular disease, if it is present, then you have to add GLP-1 first. If CKD or heart failure is there, then you have to add SGLT2 first and then GLP-1.
Thank you.
Because this is the way this compelling indications. Compelling indications have been very clearly defined.
In the interest of time, let's move. Just one question from the audience. So somebody is asking, what about type 1 diabetes patients? Would you use any of these two molecules in type 1 diabetes for pleiotropic benefits?
Under trial, SGLT2 in type 1 is there. We can't off-label. They are being used in America as plethoric. I mean, many people are using, but then data are awaited from type 1 where they are trying it, SGLT2 inhibitors.
Need to be very careful.
One thing, in type 1 diabetics who are about 21 years of age, still there is approval as of now in 2021 for giving SGLT2 inhibitor. Those who are type 1 diabetic and more than 21 years of age, there is data.
So
I do agree with Dr. Lalwani. Lalwani sahab, pad lijiye, hai approval.
Primary objective is to protect end organ damage.
Yes.
And A1C is associated with that. So we have to see both. We have to protect the organ and we have to keep it that the patient should not go into hypoglycemia.
Absolutely, sir.
That's where A1C comes.
Protection ही कर रहे हैं, GLP-1 और SGLT2 से end organ protection ही कर रहे हैं, sir.
Exactly.
So I hand over session to our respected chairpersons if they have any comments or concluding remarks for this session. Thank you, panelists. Dr. Tarun.
Yeah, thank you, Dr. Arun Singh, for introducing us to the topic in a very nice way. And I'm also grateful to the esteemed faculty, Dr. Shukla, Dr. Brij, Mohan, Dr. Lalwani, and Dr. Arora, for introducing to this interesting topic of game changer drugs in terms of cardiorenal protection. There was a very healthy discussion. And now I request the organizer to introduce us to the next topic, please. Thank you.
Thank you, everyone. Thank you.
Thank you. Bye-bye. Thank you. Thank you, my co-panelists and chairpersons. Thanks a lot.
Thank you.